So my name is Abdulkader. Today I will be doing a MSI review session with like questions and whatnot. I'll just be doing the musculoskeletal part. I believe you're doing the dermatology part tomorrow. So I think let's just get started. I don't want to waste too much time. I know your exam is coming up. This is the first question. The way we're gonna do this is I'll give you guys a bit of time to read it yourself and then give your answers, and then I'll go through it with you guys. And then afterwards, for some of the I think more important topics, I kind of put summary slides afterwards. So we'll just do it that way. So this is the first question. And feel free to put your answers in the chat, or if you want to unmute, you can unmute. That's fine too. Okay. I think it's enough time. Let's go through it. So a 68-year-old man comes to the physician because of a 5-month history of undulating, dull pain in his right thigh. Physical exam shows a tender, round mass located above the right knee on the anterior aspect of the thigh. An X-ray of the right thigh shows sunburst pattern of osteolytic bone lesions in combination with sclerotic bone formation and invasion of the surrounding tissue. Despite limb-sparing attempts, the patient has to undergo amputation of the right leg. A photograph of a cross-section of the affected leg is shown, which of the following is the strongest predisposing factor for the patient's condition. Okay, so you say osteosarcoma, therefore it's Paget's disease. Yes, so the answer here is most definitely A. Now, what are we looking at here in the question? We're looking at the age, right? It says 68-year-old man, right? We're looking at it's chronic, so obviously it's cancer, and we're looking at where it is. Okay, it's in his knee. Osteosarcoma often happens in the knee. Now they gave us some clues here. They said sunburst pattern, right? And they said sclerotic bone formation. And so these, I guess you could say, buzzwords kind of clue you in to the fact that it is osteosarcoma. Also, you don't need the picture here. It kind of just helps out. But I think just from the question alone, with the age and the X-ray findings, you should be able to figure out this is osteosarcoma. And then if you go through the answer choices, it can't be Gardner syndrome. Gardner syndrome is associated with benign bone diseases. Can't be T1122. Can't be hyperparathyroidism. Can't be FGF. Can't be tuberous sclerosis. I don't even think you guys took this, so I would just completely get rid of that completely. So that leaves us with the only valid option, which is Paget's disease. Any questions about this? Clear? Perfect. So we'll move on to the next question. Okay, this one's a little bit easier. A 14-year-old boy is brought to the physician by his mother because of a 1-month history of pain in his right leg. His mother has been giving him ketorolac at night to improve his sleep, but the pain has not improved. Physical exam shows marked tenderness along the right mid-femur. An X-ray of the right lower extremity shows several lytic lesions in the diaphysis of the femur, and a surrounding cortex covered by several layers of new bone. A biopsy of the right femur shows small round blue cells, which of the following is the most likely diagnosis. You guys are saying A, Ewing sarcoma. Okay, which is correct. This is, I think, a fairly easy question. Again, what you want to look at in these questions is one, the demographic. Who is the patient? How old are they? Right. Secondly, you want to look at where is the lesion, diaphysis. Okay, so that'll kind of narrow down what the possible bone cancers are. Then most of the time they'll give you buzzwords, right? So the buzzwords here, obviously, the several layers of new bone. That's the onion skinning, and then we also have a biopsy which shows small round blue cells, which is Ewing sarcoma. Any questions about this one? I feel like this one was a bit easy. Clear. Okay. And this next slide, just a bit of an overview on the different malignant bone tumors. Osteosarcoma, as we said, when it's in younger patients, primary, it's not really associated with much of with Paget's disease or any of the other syndromes. But you notice in older ages, like the patient that we had over here, 60-year-old man, will notice that the risk factors are Paget's disease, familial retinoblastoma, etc. You want to look at the location, okay? Here, metaphysis, diaphysis, and you want to look at these buzzwords. These are what you're looking for, right? Sunburst appearance, Codman's triangle. And these are also, if they give you an X-ray, you're going to want to look for this stuff, right? Ewing sarcoma, small round blue cells, onion scanning. This is very important. They ask about this a lot. T1122. Chondrosarcoma, not as high yield, but this is just a bit of an overview of chondrosarcoma over here. They'll say moth-eaten appearance, but I think just be careful about that. You got to kind of look for other stuff that'll lead you towards chondrosarcoma. I don't think it's necessarily 100% chondrosarcoma. I think we can move on. Also, I put a picture here. This is from first aid. Kind of helps out with which. So epiphysis, the only main one you got to know is giant cell tumor. Metaphysis, the important ones are osteosarcoma, osteochondroma, and then diaphysis, Ewing's, and osteosteoma. Those are the main ones that you got to know. So location is very important. Next question. Okay, so this one is a little bit of a more difficult question. I was kind of debating whether or not to put it in because when it comes to pharma, depending on what doctor taught it to you, depending on what they thought was important, you might have learned different things. But can anyone tell me what the drug is at least? So we have here a 72-year-old man, right? Progressively worse pain on the right side of his face. He's undergoing treatment, and here, this is what we're looking for: swelling over the right cheek and mandible, right? This is osteonecrosis of the jaw. Yes, correct. So what drug that you guys learned is associated with osteonecrosis of the jaw? Yes, bisphosphonates. So this is an important, rare but important side effect that you guys should know. The answer here is E. I believe if you go to your lectures, it will be mentioned, but I don't know how much emphasis, I don't know who taught you the lecture. I think it was Dilip, but I don't know how much emphasis they put on this. That's why I was kind of hesitant on whether or not to put this in the lecture. I hope that's clear. If it's not, please let me know. Okay. Okay, yeah. As long as you can figure out from osteonecrosis of the jaw that this is associated with bisphosphonates, I think that's more important. Okay, we'll move on to the next question. Okay. A 40-year-old woman comes to the physician with 2-month history of chest pain and heartburn after meals. Patient reports that the pain is worse at night and especially when lying down. She has history of occasional small joint pain and Raynaud's disease treated with nifedipine. There's no family history of serious illness. She immigrated to the United States from Nigeria 5 years ago. She does not smoke or drink alcohol. Vital signs are within normal limits. Cardiopulmonary examination shows no abnormalities. Thickening and hardening in the skin is seen on the hands and face. There are several firm white nodules on the elbows and fingertips. Further evaluation of this patient is most likely to show which of the following findings. Okay. Now, be careful here, because here the antibodies are very important. They get asked a lot, and they can get kind of confusing. let's look through the symptoms that she presented with, and then we can kind of come to a conclusion on what the disease is. First of all, it's a 40-year-old woman. Okay, always look at the demographic first. Who is the patient? Women, middle-aged women, they're the ones who are most likely to be affected by autoimmune diseases. It says she comes with 2-month history of chest pain and heartburn. Now, this will be an esophageal problem, right? Heartburn and chest pain. This is, especially after meals, this means there's something wrong with her esophagus. And then they say here, it's especially bad when lying down, okay? They say she has small joint pain and she has Raynaud's disease, right? She also says that she has thickening and hardening in the skin and several firm white nodules. Okay. Now, I noticed in the chat that some people are saying systemic sclerosis, some people are saying limited sclerosis. Now, here we have calcinosis, right? We have Raynaud's, we have esophageal dysmotility, right? Now, we have the sclerosis, right? Now, they don't mention the telangiectasias, but this is basically telling you this is Crest's disease. And which one of these antibodies is associated with Crest's disease? The answer here is D, anticentromere. An easier way to remember that is to just think of the C for calcinosis. Think of that as centromere as well, anticentromere calcinosis. That's just an easy way to remember. So people who are saying E, that is not limited, that is diffuse. Exactly, right? So here we have just a bit of an overview of scleroderma. The problem is I don't think that you guys take a patho lecture on scleroderma. I know that we didn't. And because of that, I know a lot of people don't really go into it as much because I think there's only a clinical lecture on it. But it is tested heavily. It came to us as an SAQ. They asked us, literally just asked us, what does CREST stand for? And what are the antibodies? So definitely know scleroderma very well. This is just a basic overview. I kind of want to go over this instead because just the differences between limited and diffuse. Now here, what you're looking at is in limited, it's the Crest syndrome, right? And then the serology is anticentromere. And then we have the anti-SCL70 and the anti-RNA polymerase. Now they can also put the anti-SCL70 as anti-DNA topomerase, right? So you should know both of them because sometimes they like to trick you and put the other one. So definitely know the antibodies very well. Know which antibodies are for which disease, right? Because they do ask about it. Yeah, I think you only take it as clinical, and it comes as a PBL case, I think, but you don't take it in pathology, so you might not think it's as important, but it is very important. Does anyone have any questions about scleroderma? Okay, no questions, then I'll move on. Okay. Let me go through the question. A 26-year-old African-American woman comes to the physician because of a 3-week history of non-productive cough and chest pain. The pain is sharp and worse when she inhales. During this time, she has also had 2 episodes of hematuria. Over the past 6 months, she has had intermittent pain, stiffness, and swelling in her fingers and knees and left knee. She's had 2 miscarriages at age 22 and 24. Her only medication is minocycline for acne vulgaris. Her temperature is 38. Blood pressure is 138/85, pulse 75. Physical examination shows erythematous rash on her face. There's mild tenderness over the metacarpophalangeal joints bilaterally with no warmth or erythema. Further evaluation is likely to show which of the following findings. Okay. Now, the problem with these rheumatology questions is that a lot of these diseases, they like to overlap. So what you really want to do is you really want to see, okay, what are the differences between the diseases, right? So here, again, we have 26-year-old woman, middle-aged woman, most likely autoimmune disease. Now, pain is sharp and worse when she inhales deeply. This is pleuritis, okay? This is pleuritis, and also it says 2 episodes of hematuria. This shows a renal issue, right? It says intermittent pain, stiffness, swelling over fingers. This is arthritis. 2 miscarriages, right? Recurrent miscarriages. What is that associated with? Antiphospholipid syndrome. Yeah. Now, with all, and then it also says erythematous face rash, right? Now, all of this tells you it is SLE. Now, of the ones here, the one that is associated with SLE would be B. Now, why is this important to know? Because SLE is what type, do you guys know what type of hypersensitivity reaction SLE is? Type 2. Okay, no, so it's actually interesting. It's a type 3 hypersensitivity reaction, right? Which is antigen antibody immune complexes. But what you have is you have the hematologic disorders, and these specifically are type 2. I don't know how important that is for you, but what you should know is it's type 3 overall. Most of the symptoms would be type 3. And the early complement proteins, what they're supposed to do is they're supposed to get rid of those antigen antibody complexes. So the deficiency in those is what kind of lets those complexes stay. And that's what causes a lot of the symptoms, right? And so what you want to look at here is you want to look at, I think in your lecture they have major, minor criteria, but this is more just for like the question stem. What you want to look for, you want to look for the rash. You want to look for arthritis or ascites. You want to look for this kind of rash or pain. Mnemonic is really good. And if you find 4 of them, I think that's the number. If you find 4, with those, like you see all those symptoms together. Also, what they like to do is they like to use the ones that you're kind of not focused on. So everyone thinks of SLE, rash, arthritis, right? But nobody really remembers serositis. Nobody really remembers oral ulcers, right? So they'll kind of put the ones that you don't really remember. So because rash, arthritis, these ones are kind of obvious, but the ones that you kind of forget, those are the ones you want to focus on. Those are the ones they like to put in questions. Now, for lupus, it's important to know lupus nephritis. It is the most common cause of death. And in case it comes in your exam, anti-dsDNA is the one that's associated with renal nephritis. Nephrotic syndrome, nephritic syndrome, you're going to take that in renal, but just I think what you should know is associated with membranous nephropathy and diffuse proliferative glomerulonephritis. Also, anti-SSA is associated with neonatal lupus. I'll go over more of the different antibodies for the different diseases later. But yeah, what you want to know for SLE is it can affect almost anything in the body, right? And so you want to know all these symptoms, because otherwise you won't be able to tell, okay, what diseases, because all the autoimmune diseases, they overlap. So it's difficult. So memorize the antibodies and memorize the symptoms. Any questions? Okay. Next question. Okay. 57-year-old man comes to the physician with sudden onset fever, malaise, and pain, swelling of the wrists, ankles that began a week ago. 1 month ago, he was started on hydralazine for adjunctive treatment of hypertension. Okay, it seems like people already know. Okay, so this is drug-induced lupus, which means the answer here would be D. So for drug-induced lupus, there's a bunch of drugs that are associated with it. I think go to your lectures and see which ones they want you to know, but the most important ones, in my opinion, are hydralazine and procainamide. Methodopa as well. What you'll notice, sometimes they'll put in the question, sometimes they won't. They didn't put it here, but when you take away the drug, the symptoms stop. Here I put basically different antibodies that you guys should know. There are more than this, but these are like a lot of the important ones. I already mentioned anti-dsDNA, anti-Smith, antihistone associated with drug-induced lupus. Anti-SSA, SSB is Sjogren's syndrome, but it's also associated with neonatal lupus. Anti-centromere rhicitis crest. We mentioned systemic sclerosis. Anti-RNP is mixed connective tissue disease. I think they say EU1 RNP. And then rheumatoid factor or anti-CCP is associated with rheumatoid arthritis. And another just tidbit in case they ask is the neonatal SLE is associated with AV block or heart block, just in case they ask. Any questions about this? Also, you guys should know about the dermatomyositis and polymyositis. Know about those. That's basically the only thing. No, I don't think it's high yield for MSI at least. No polymyositis, dermatomyositis, antibodies. I'll get to it later, but those are very important, and that's pretty much the most important thing to ask about that. If everything else is clear here, I'll move on to the next question. Yeah, anti-Joe, anti-me too. Everything clear? So I'm not sure about NTSSB, but it's definitely associated with NTSSA. I'll move on. Okay. A 47-year-old woman comes to the physician because of body aches for the past 9 months. She also has stiffness of the shoulders and knees that is worse in the morning and tingling in the upper extremities. Examination shows marked tenderness over the posterior neck, bilateral mid-trapezius, and medial aspect of the left knee. A complete blood count and erythrocyte segmentation rate are within reference ranges. Which of the following is the most likely diagnosis? So what we have here, we have, again, 47-year-old woman, and we have very vague symptoms. We have marked tenderness. We have tender points in certain areas. We have normal lab values. Exactly. So the answer here is fibromyalgia. Now, what you'll notice in these questions is that they have very vague symptoms. They have fatigue. They have pain. They have just random tender points in the back and the shoulders and pelvis and whatnot. And the very important thing to know is that the lab values are all normal. This is from UWorld. This is just goes over the important things: musculoskeletal pain, fatigue, and this, I think, is one of the more important things, is you have normal inflammatory markers. Symptoms also should last for more than 3 months. In our case, it is 9 months, right? And yeah. Any questions about fibromyalgia? I think this is pretty easy. Okay, I'll move on to the next question. Okay. A 4-year-old boy is brought to the emergency department for a right ankle injury sustained during a fall earlier that morning. His parents report that he is clumsy when he runs and has fallen multiple times in the year. He has reached most of his developmental milestones, but did not walk until the age of 17 months. He's an only child and was adopted at the age of 1. He appears tearful and in mild distress. His temperature is 37, pulse 72, respiration 17, and blood pressure is 80/50. His right ankle is mildly swollen with no tenderness over the medial or lateral malleolus. Range of motion is full with mild pain. He has marked enlargement of both calves, patellar and Achilles reflexes 1+ bilaterally. Strength is 4/5 in the deltoids, knee flexors, extensors, and 5/5 in biceps and triceps. Babinski is absent. When standing up from a lying position, the patient crawls onto his knees and slowly walks himself up to his hands. Which of the following is most likely underlying mechanism of this patient? Okay. Yeah, so you guys seem to know this. So this is Duchenne's. So as Walid mentioned, this last line, this is Gower's sign, right? Patient crawls onto his knees, slowly walks himself up with his hands. But let's start from the beginning, all right? First of all, young patient, right? Duchenne's will always come young. Clumsy, right? They fall a lot. They say here he has marked enlargement of both calves, which is calf pseudohypertrophy. And so the answer here would be the absence of dystrophin. And I feel like in general, this is pretty self-explanatory, right? The proximal muscles get replaced with fat. What happens is the reason why you have calf pseudohypertrophy is because at the beginning your proximal muscles are gone, so they start to walk on their toes. When they walk on their toes their calves start large, and then once their calves are large, then the fibrofatty replacement comes in and becomes fat, right? So it's already enlarged because they're walking their toes, but then now that becomes replaced by fat. So that's why you have pseudohypertrophy. You have waddling gait and Gower sign. This, what I put here in red, this is very important. This is what mostly gets asked about this disease, most common cause of death, dilated cardiomyopathy. But I think you guys took some genetics, so you might get asked if it's X-linked recessive in case you get asked. Duchenne's is frame shift, deletion of dystrophin. Becker's is non-frame shift. And so because of that, Becker's is less severe. What you'll notice is in Duchenne's, what happens is that by like 13, they're in a wheelchair. By like 20, they're dead. By Becker's, you'll find it'll be an older patient. So like 25, 26, they'll come in in a wheelchair, or they'll come in with these signs and symptoms much later on. So that's just the main difference between them. I put here an image of Gower sign. You guys all know what that is. Is that clear? Okay, perfect. Okay. Let me read the question with you. A 70-year-old man is brought to the emergency department because of a severe back pain that began when he was lifting a box 1 hour ago. He also has a 2-year history of increasingly severe right hip pain. Physical exam shows tenderness to palpation of the lower spine, as well as erythema of the skin over the right hip. Neurologic exam shows decreased hearing in the left ear. The Weber test localizes this to the left side. Serum studies show ALP concentration of 410, calcium concentration of 9.5, and PTH of 32. An X-ray of the spine shows a fracture of the L4 vertebra. Which of the following is the most likely diagnosis? Okay, now I want you guys to be very careful here. I put the normal lab values so that you guys can know what the lab values are. Because or which is elevated, which is not elevated, because it makes a big difference. And I think with the lab values, you should be able to answer the question no matter what. So we have here ALP is 410, right? ALP is elevated, calcium is normal, and PTH is normal. Now you guys are saying F is osteopetrosis, right? Osteopetrosis, it does not have an elevated ALP. Why would you have an elevated ALP? For what reason? Does anyone know? Exactly. Okay, so ALP is secreted from osteoblasts. Now, what is the problem with osteopetrosis? It's not a problem of osteoblasts. It's a problem with osteoclasts, right? So you wouldn't have elevated ALP because you don't have elevated or extra osteoblasts. There's no problem with the osteoblasts. So the answer here is actually D. Now, what is D? Does anyone know what D is? D is Paget's disease. Now, the reason I put this question is because they do this. They'll put the other name for Paget's disease. So osteoitis deformans is Paget's disease. And so just to trick you, they'll put the second name. So what do you have in Paget's disease? You have an isolated elevation in ALP, right? It affects older ages. You guys know the pathophysiology. I won't go through the pathophysiology with you. You have a large head, deafness. All these you'll see over here. He said decreased hearing, right? Sometimes they'll mention that their hat sizes, right? And so let me go to the lab values. What you'll see is in Paget's disease, you'll see everything is normal, which is what we saw, and we'll only see elevation ALP. Okay? Because ALP, osteoblasts need ALP to mineralize bone, right? And so in Paget's disease, if you see isolated ALP, first thought is Paget's disease. In osteopetrosis, you won't get elevated ALP. You get normal ALP, right? Osteoporosis, you get normal everything. Because what is osteoporosis? It's just a normal physiologic process. What happens is, especially it happens in females, is they lose estrogen and then their bones start to, they get less turnover, right? And then osteofibrosis cystica, primary hyperparathyroidism, what you get is you get high PTH, even though there's high calcium. Now, the role of PTH is if there's low calcium, PTH will go up to increase the calcium, to bring it up to speed. But in primary, they're both elevated, right? And that's where you get these brown tumors. Secondary is the opposite. Secondary, normally due to renal failure, you'll have low calcium, chronically low calcium. It just keeps going down, and no matter how high PTH goes, it can't get up to the same level, right? It can't get calcium up to its normal level. And then osteomalacia is vitamin D deficiency. Osteomalacia is in adults, rickets is in children. Does that make sense? I want you guys to know that. Where's the question? I need you guys to know that this is Paget's disease. This is just another name for Paget's disease. You'll see it in your first aid book. This is a name that they like to use to trick you, to confuse you, but this is Paget's disease. So don't get confused with the other options. Okay, perfect. Let me move on. Okay. Okay. An 11-year-old boy is brought to the physician by his parents because of a 2-month history of progressive swelling of his right upper arm. He has otherwise been healthy. Medical history is unremarkable, and he takes no medications. Immunizations are up to date. He appears well nourished and well developed. He is at 60th percentile for height and weight. Vital signs are within normal. Physical exam shows an immobile mass on the right proximal humerus that is non-tender to palpation. ESR is 10, ALP is 35, and X-ray shows a 3 centimeter sessile bony protrusion with a cartilage cap on the proximal metaphysis of the right humerus. Which of the following is the most likely diagnosis? Yes, the answer here is E, osteochondroma. So I think just like you said, I think forget about the rest of the question. If you just look at the X-ray right here, it says bony protrusion with a cartilage cap, right? That is, in essence, that is what osteochondroma is. If you go to just this overview of the benign bone tumors, yeah. What I think is very important to know, because this comes, like, the clinical doctors like to ask this type of stuff. Most common bone tumor is metastasis, right? Primary disease is not as common as metastasis. Metastasis is much more common, all right? But most common benign bone tumor is osteochondroma. Like I said earlier, what you want to look at is, you want to look at, first of all, the epidemiology. You want to look at what is the age, right? Here's 11-year-old boy. You want to look at the location, right? Metaphysis, where is it happening? And then there are just some characteristics. Each thing has like their own, characteristic. Giant cell tumor, very characteristics, so bubble appearance, right? It's the only one that you have to know that's important, that's in the epiphysis, right? And so if you just know these things, I think it'll help you answer all the bone tumor questions, unless they ask like gene mutations and whatnot, which I remember Arban told us we didn't have to know that. I don't know if it's the same for you guys. So if he told you have to memorize them, I'd say memorize them, the SQ, ST, M1, whatever all that stuff was. If he told you have to know them. Otherwise, otherwise with this stuff alone, I think you should be able to answer all of the questions. Just epidemiology, the age of the patient, location, and if they'll give you a characteristic finding. And that alone, I think all bone cancer questions should be pretty easy. Is that clear? Any questions? Perfect. On to the next question. All right, seems like people are answering already. A 31-year-old woman comes to the physician because of a 2-day history of low-grade intermittent fever, dyspnea, and chest pain that worsens on deep inspiration. Over the past 4 weeks, she has had pain in her wrists on both fingers of both hands. During this period, she has also had difficulties working on her computer due to limited range of motion in her fingers, which tends to be more severe in the morning. Her temperature is 37.7. Physical exam shows a high-pitched scratching sound of the left sternal border. Further evaluation of this patient is most likely to reveal which of the following findings. Yes, rheumatoid arthritis. So the answer here is D. I think a fairly simple question. They give you some of like the associated symptoms. Also, to differentiate between osteoarthritis and rheumatoid arthritis, you kind of want to look at where is the pain. It's symmetric here, right? That's what it says. And then they also say that it's worse in the morning. It's most severe in the morning. And the osteoarthritis gets worse as the day progresses. Rheumatoid arthritis is worse in the morning. And they give some more, symptoms. So this is just an overview. What rheumatoid arthritis is autoimmune, right? Leads to a pannus formation, and this kind of helped me understand it. I hope it helps you. So the pannus is just granulation tissue, right? And so the myofibroblasts within the granulation tissue, what do? It kind of pulls the joints, right? It'll pull it together, first of all, and pulling it together is what will cause like those erosions. And then, or like fusion, like the narrowing and the fusion, that's caused by the myofibroblasts pulling the joints together. And then pulling it like apart in different like ways, that's what causes like the swan neck and the boutonniere deformities. So you remember like that, it becomes more easy. You should know the symmetric is important. That's a way to differentiate it. It spares the DIP, which is different than osteoarthritis, which does affect the DIP. Atlantoaxial subluxation, this is something that they like to ask about. So you should know that as well. And also systemic symptoms. So the reason I put cardiac manifestations here specifically is because this came as SAQ for us, which the SAQ literally just read what are the cardiac manifestations of rheumatoid arthritis. It was mentioned nowhere except for a clinical lecture. So make sure you do Sahibani's clinical lectures very well, because it does come. I think there's more than just a cardiac, lung, eye, whatever. It has all the manifestations. So know them in case it comes as SAQ, because it came as SAQ for us. Rheumatoid nodules, another one. And then treatment. I'm not going to go that much into the treatment, but this is just a brief overview. I feel like I probably should have put osteoarthritis here next to it. I apologize for that, but I hope it's clear anyways. Perfect. Also, another thing for all this stuff, someone came up to me and asked me about the radio. So for radiology, definitely do not skip radiology. It is important for us. I think we had like 8 questions in OSPE, or 6, like a lot of questions. All the questions in OSPE were radiology. So know the radiology pictures very well, because it does come. I think Dr. Jamal is the doctor. I think he's one of the better radiology doctors. So even if you don't want to watch, at least do transcriptions, do something, because radiology is very important. And if you can recognize the pictures, because most of the time they'll use the exact same pictures as they use in their PowerPoints. So just know radiology very well. And also histology, because histology will come in OSPE, it'll come in MCQ. Don't skip histology. It comes. We'll move on. Okay. So this is a bit of a tricky question. I'll tell you that. A 64-year-old man comes to the emergency. I lost the pen. Okay. 64-year-old man comes to the emergency department due to acute knee pain. He developed redness, swelling, and severe pain affecting the right knee the day before his arrival. Patient has 3 similar episodes in the past year and resolved quickly with over-the-counter analgesics. His history of polycythemia vera, but has been non-compliant with phlebotomy treatments. Vital signs and cardiopulmonary examinations are normal. The right knee is red and warm. There's severe pain with movement at the joint. Other joints are grossly normal. Needle aspiration is going to show what is it going to show. Now, you guys are saying G. The reason I know why you guys are saying G, because it's affecting the knee, right? And it's an old patient, affecting the knee. It's probably G. But here, what you got to look at is why did they tell us this? Why did they tell us that this patient has polycythemia? Polycythemia means increased turnover of cells. Increased turnover of cells can predispose to which disease? Okay, I'll just say. So increased turnover of cells, especially red blood cells, means increased purines, increased RNA in the blood, right? Increased RNA, increased purines means increased uric acid. Now, increased uric acid is gout. The reason why it's not septic arthritis, because they would have mentioned that he has a fever or something like that. She has no fever. So the answer here is E. So with gout, there's 2 main causes of gout, right? There's decreased urate clearance and there's increased urate production, right? So here, it's a myeloproliferative disease, right? PCV, polycythemia vera, right? Means more cell turnover, means more urate production. And that's what's causing the gout. Now, just because it's not in the toe doesn't mean that it's not gout, right? So I know that, calcium pyrophosphate is seen in pseudo gout, right? It's often idiopathic, commonly affects the knee. So just because it's affecting the knee doesn't mean that it has to be pseudo gout. Most of the time it will be pseudo gout, but you got to look at what are they telling you in the question? What are they giving you? Here they're telling you he's non-compliant with this treatment, right? Which means that the disease is getting severe. So that's why, so the risk factor is hyperuricemia, right? That's due to increased urate production. Now, can someone tell me what this disease is? Lesch-Nyhan syndrome. Exactly, HGPRT deficiency. I think it's the only important thing from that lecture, in my opinion. But from the biochem lecture, sorry. They'll say that he'll have some kind of mental retardation. He'll like to eat rocks or like stuff like that, pica, whatever. And so it is an HGPRT deficiency, correct? Acute attack often follows consumption of red meat, seafood, alcohol, or it could be due to dehydration, diuresis, anything that causes increased urate in the blood, right? So I think these are the important differences between gout and pseudo gout. Definitely know what they look like under a microscope, right? Rhomboid crystals. You guys kind of knew that this was pseudo gout. That's good. And definitely know what they look like under parallel, right? Blue, yellow. So the way first it says yellow, parallel, 2 L's. However you want to remember it, but it's very important. Even the pictures, I think you should remember the pictures. I think it's fairly easy. One of them is crystals, one of them is needles, but I just remember that stuff. So yeah, so polycythemia is a MPD, a myeloproliferative disorder, right? So polycythemia means increased turnover of red blood cells, right? Increased turnover of red blood cells means increased RNAs, increased urate in the blood. And the hyperuricemia obviously predisposes to gout. So just because it's in the knee doesn't necessarily mean that it's pseudo gout. In this case, it was gout. Although the classic is the big toe, but they won't always tell you that it's the big toe, right? They'll try to trick you. So that's why I didn't want to make the questions too easy, too obvious, because if I make it too easy and the exam's harder, then it doesn't make sense. If I'm harder than the exam, then that's good. Does that make sense? Okay, good. Okay. A 35-year-old man comes to the clinic with acute right knee pain and swelling. His symptoms have been present for a week and have moderately worsened over this period. The patient is able to bear weight but has significant pain when climbing the stairs or walking for extended distances. He attended treatment with ibuprofen, which provided prompt but only temporary relief. Past medical history is unremarkable. The patient was seen by his primary care physician for diarrhea 2 weeks ago. Examination shows moderate size effusion of the right knee. Culture reveals no bacteria, which of the following is most likely associated with the symptoms. So the answer here is C. What is the disease? It is seronegative spondyloarthritis. So this one is actually specifically, this one is reactive arthritis. So they said that he had diarrhea 2 weeks ago, right? So what happens in reactive arthritis is you have some kind of GI infection, some kind of infection, right? In this case, most likely it is Campylobacter. And then afterwards you get arthritis, right? So the different HLA-B27 diseases can be remembered with pair. Psoriatic arthritis, right? You have the sausage finger. This came in OSPE, the picture of this. No, not this one. This one, sorry. Pencil and cup. This one came. You have ankylosing spondylitis, where you have bamboo spine. You have iritis, uveitis. You also have IBD, which is Crohn's or ulcerative colitis, and you have reactive arthritis, which is what this patient has, which has the classic triad, which they didn't show here, but oftentimes they will show is conjunctivitis, urethritis, arthritis, which you can remember as like can't see, can't pee, can't climb a tree. And so also another thing, I assume Arman told you guys this, he tells every batch this, that I will in a second, that he actually had this disease. He had reactive arthritis when he was in the US or something. And so another thing that you should associate with this is Achilles tendonitis, because he said that was the disease that he had. He had Achilles tendonitis with this. And so I think that in case like he feels like he wants to put it in the exam, he might put it because he actually had it. So remember, associated with this is Achilles tendonitis. So the reason why, so that's the main reason. So what we're looking at here, right, is this patient had a diarrheal illness 2 weeks ago, right? And what happens is after the diarrheal illness, you get these symptoms of arthritis, right? Right knee pain and swelling. And so none of the other answer choices here would make sense. C1 inhibitor deficiency happens in children. It's autoimmune disease. You have this is strep, right? This would not be strep. Just ANA, positive serum ANA, that doesn't mean anything on its own, right? Yeah, so they don't always have to give you all the what's it called, symptoms. Exactly. So just because they don't give you all the symptoms, just because they don't give you everything you're looking for, you have to work with what they did give you, right? And so what did they tell you? They told you he had diarrhea 2 weeks ago, and now he has arthritis. So what kind of leads you towards, okay, it could be reactive arthritis, even though it's not necessarily he has all the symptoms. Enterohepatic arthritis. Honestly, even if it could be enteropathic arthritis, I'm not sure about that. I don't think so, but I wouldn't really be able to answer that question. I'm sorry. Okay, so regardless, as long as you get to the right answer, the answer here is C, right? As long as you get to this answer, that's what's most important, right? I hope that makes sense, because none of the other answer choices here really make sense. If you look at like the different answer choices, none of them really make sense, right? If you look at like, it can't be rheumatoid factors, it can't be rheumatoid arthritis, right? It can't be ANA not specific to any disease. ANA is just positive in autoimmune disease. It's not specific to anything. It can't be ASO, it's not group A strep, right? And then A, I don't even know if you guys took it, but it's angioedema, like hereditary angioedema of the face. So it just does not make, none of the other answer choices really make sense here. I hope that's clear. Okay. And again, in the PowerPoint, I kind of, in the notes, I put like the explanations behind why this is the right answer and then why the other ones are wrong. So afterwards, I'll send the PowerPoint to whoever the PAL guy is. I'll send it, and then you guys can look at it yourselves if it's unclear from now. I think there's 2 more questions, so I'll give you a chance to read this one. This one's important. Okay. A 48-year-old woman, previously healthy woman, comes to the office due to progressively worsening muscle weakness for the past 2 months. Patient has difficulty with activities such as climbing the stairs, getting up from chairs, and placing dishes in overhead cabinets. She also reports 10-pound unintentional weight loss and occasional abdominal discomfort over the same interval. Physical exam shows weakness of the shoulder and hip girdle muscles. Other exam findings are shown in the image below. Further evaluation of this patient is most likely to reveal which of the following associated conditions. So someone mentioned in the chat that this is the Gutron. These are called Gottron's papules, however you want to pronounce it, right? And it is characteristic of dermatomyositis. Yes. So the answer here would be ovarian adenocarcinoma. Now, it is important that you know that it's not just GI malignancy. It's associated with occult malignancies, and GI malignancy is one of them. So I think, I don't remember which malignancies. I'm trying to remember. I think, okay, it's ovarian malignancies, colorectal malignancies, and lung malignancies. Those are the 3 main ones. I think it's also associated with non-Hodgkin lymphoma, but I'm not 100% sure about that. But basically, the main point is, what you want to know is dermatomyositis is associated with malignancies. Again, yes. So that's another thing you can look at, right? So it is unintentional weight loss is associated with cancer. But what you want to know is that this is dermatomyositis. That's good. So you figured out this is dermatomyositis. But what you want to know is it is associated with occult malignancy, because what they do is they know you can easily, right? You can easily guess that this is dermatomyositis. They're not trying to make the disease, or kind of trying to figure out what the disease is. They're not trying to make that hard. They want to know, how well do you know the disease, right? How well do you know the other symptoms of the disease? So it's important to know the antibodies. Antibodies are very important. I think they always ask about these antibodies, anti-Joe, anti-me too. I remember he literally told us that I will ask you about these antibodies. So I assume he'll also ask you about these antibodies. Also Gottron papules. So the difference between dermatomyositis and polymyositis. Okay, perfect. It's basically the same, except dermatomyositis is the cutaneous. It has cutaneous involvement as well. So that's where you get the heliotrope rash, the swollen face rash. And so this is basically what I was trying to point out here, is that it has increased risk of occult malignancy. So it's good it's mentioned in your lecture. Is this clear? Is this concept clear? Non-Hodgkin lymphoma, lung cancer, stomach cancer, colorectal cancer as well. Perfect. Okay. Great. This is the last question. Okay. A 24-year-old woman comes to the office at 12 weeks gestation for prenatal counseling. She is 120 centimeters, 3'1", with short upper and lower extremities, but normal torso. Physical exam is also significant for depression of the nasal bridge, bulging forehead. Her husband is phenotypically normal and has no medical problems. The patient knows that there's 50% chance of passing on her condition to the fetus. An abnormality involving which of the following cells is most likely responsible for this patient's features? Yeah, so this one's pretty easy. So it's just chondrocytes, right? And so what's important to know is this is achondroplasia. What's important to know is that it is an activating mutation in FGFR3, because you'd think activating mutation stops fibroblast growth factor, but yes, it does. So this mutation stops FGFR3, it stops endochondral ossification, right? And so that's why their long bones don't get long, right? But their head stays normal. So their head is the other membranous ossification, right? And so that's where their head stays normal size, but the rest of their body becomes short. And this disease has 100% penetrance, I think that's the word, which basically means that if you have this mutation, you will 100% show the signs. I think you guys took this in genetics, so this is the most important thing. FGFR3 activating mutation. They'll tell you most of the time the parent will also have the same thing, right? They'll tell you that the limbs are short, but the head is disproportionate to the limbs. I don't think they'll give you I don't think you need to know the rest of these, but just in case, I put it here anyways. And I think that's it for this question. Is everything clear? Okay. So that's it for my review session. If anyone has any other questions, please let me know. I know you guys have derma tomorrow, but just some like important things that you guys should know about dermatology. Just know the difference between pemphigus vulgaris and bullous pemphigus. Know like the desmosomes versus hemidesmosomes, which one's more lethal, pemphigus more lethal. Know which one has the tense blisters. They'll show you pictures of blisters, and then they'll ask you what is this. They'll show you I think the introduction lecture where he defines what's a macule, what's a papule. He'll ask for the definitions of that stuff. Definitely know all those definitions because he will ask them. Also, melanoma is very important. Know the A, B, C, D, E. Know yes, and MCQ. He'll say which of the following is a macule, and then it'll be the different definitions. Know the Breslau thickness. Know the types of melanoma and the differences. Which one is superficial spreading? Which one is poor prognosis? Know all that stuff. Off the top of my head, that's all I can. Also, clinical. The thing is with the derma clinical is, especially with like the fungi and stuff, it's not really that obvious. It's kind of random stuff in my opinion. So I would go through it and make sure you know the stuff that they talk about, because I remember when like in our exam, some of like the most random questions would come from derma clinical, just be random fungi that because I didn't really go over it, which is probably my fault, but it was just really random fungi that you don't take in micro. They asked us in OSPE, they asked us about like the Burbeck granules on OSPE. They asked in OSPE and MCQ about histo. Definitely would not skip histo. They asked I think 3 OSPE questions about histo, something like that. I would definitely, I don't know who your BLCs are, but I remember last year we almost got Urban to give us a blueprint, but it didn't work out. But what he did give us, he'd give us a kind of like a breakdown on the exam. So I don't know if you guys can get something like that. So what we got him to tell us, I'm trying to remember. He told us like the main focuses are patho. Okay, that's perfect. So patho is most important, patho, clinical, and probably pharma. He doesn't like physio as much, so you won't get as many questions from physio. And I don't think he likes biochem as much either. So I would put, depending on how much time you have, I would put most of your focus into like patho and clinical. And then don't sleep on radio. Radio is important too. Histo is important too. Sports med isn't as important. I would go over it, and I would definitely go over the past exams too. Although there's one question in the past exams about why females have ACL injuries more than males. And I'm pretty sure the answer is wrong in the past exams, because we had to get that question removed because apparently it did that bad. So I don't know, just be careful with that, but definitely do past exams because he does repeat questions. And other than that, I think it should go well. Inshallah, you guys will do great. I hope this lecture was helpful. And good luck. If you have any questions, let me know. And yeah, I'll send this PowerPoint. Great.